Good evening, everybody. Thank you so much for coming to the talk. I know it's Wednesday afternoon, and if I were you, I'd be feeling a little drowsy by now, but I appreciate seeing so many energetic faces. So I'm going to talk about a couple different techniques that I use mostly in public health work. As Alden said during the very nice introduction, that I trained as an ecological modeler, though I was always working in public health. And prior to that, my undergraduate degree was in mathematics, and I was at Brown actually for a math conference as a student, and there's a professor in the physics department, Brad Marsden, some of you may know him. He was giving a talk on climate modeling, and that was sort of what inspired me to think more about the applications of mathematics than studying math itself in graduate school. And I ended up at the University of Washington, which has a number of different applied programs and really encourages students to explore what they are. And so I went thinking I would study climate change, and then as soon as I got there, I was young and restless, and I was like, well, public health and AIDS suddenly caught my imagination, and I went there, and I've been in mostly that realm ever since for the past 17 years or so. And network modeling, agent-based modeling, they're both relatively old fields, but as computing and data science have sort of increased in capacity, both tools are much more deployed in all kinds of various projects. I'm sure you hear a lot about various applications. So why do we take a networks perspective in public health? So we don't live in isolated environments, at least I hope not. We are sort of influenced by our peers, our family, our classmates, and so forth. And even during the pandemic, when people were socially distancing and most interactions switched to online fora, it was still various forms of information or misinformation was still disseminating through online means and in turn influencing behavior. So health and behavior and our networks are sort of inextricably linked. The interesting thing about doing network analysis in public health is trying to measure how those networks look and sort of try to figure out how they can best be used in the service of public health goals. And on the right, that's a diagram from an HIV prevention intervention that we ran in Chicago, in Southside Chicago. And the purple dot at the center is the clinic or the center at the University of Chicago, where I was based at the time. And orange and blue dots around that circle are patients who had contact with the clinic, and the orange and blue dots signify whether they were aware of certain behavioral prevention strategies or not. And the reason we sort of did this data collection was because we wanted to get a representative sample of the general population of young black gay and bisexual men in Southside Chicago, and very little was known about the complexities of HIV service provision in that population. And so we ran this network study. I'll be alluding to parts of it in the talk, but my hope is to sort of make this kind of thing a little bit more concrete for you, where our study sort of spread out from the center. We recruited a few people who then recruited others, who then recruited others. And so it's called sort of a variant of snowball type sampling. And these types of processes have very direct application in public health management. So When I first started giving this type of talk a decade or more ago, at, at that time, social media was relatively new, and it used to seem to people that this was just folks jumping on the bandwagon of social networks. And this slide is sort of just there to make the point that social networks are actually have been a topic of research for decades, if not nearly a century at this point. And one of the first known examples of network analysis in health comes from a New York reform school where a few students were found to have run away, and there really wasn't a clear explanation as to what had happened. The classic perspective was to try to think what was going on in those persons' lives, and trying to look at individual criteria, and that's obviously a very important thing to do, but that didn't yield any satisfying answers. And Dr. Jacob Marino, who was a social scientist and a psychiatrist, was very interested in social behaviors, and he mapped out the network of friendships in the school system, and found that the students who had left were all part of the same clique or group, and whether a particular student had left or not had more to do with whether they were in that clique than their individual life circumstances. And so this is one of the first known examples of sort of a real world networks application. I use network science in usually in one of three ways. So the first one is classic social network analysis, where we do the kind of thing that we just discussed. We map a network through whatever means the data are collected, and look at those network structures. How many links there are, how those links are distributed, what the social mixing structures look like on the networks, that sort of thing. A second way is network sampling. So when I was going over the example slide from HIV recruitment in Chicago, that's a sampling example where people were, there's a population that has very low contact with the public health system, and in order to quantify a public health problem, we need to have contact with enough of them. And so we use social network strategies to try to bring people in to enroll in research studies. And the idea is that they are recruited to do so by their friends who match the study criteria, and come back and get and say, well, I've been referred to you by my friend, for instance. And then the third technique that I use a lot about, and I'll actually speak more about than the first two, is simulation modeling, where we basically reconstruct structures of populations and their networks on computer systems, and simulate the spread of information or a pathogen, and try to construct what different intervention strategies how they might benefit. Because, for instance, coming through 2-3 years of the pandemic, I think it's very clear that real-time decision-making can't always wait for long, expensive clinical trials. And so if we have reasonably representative models of real-world processes, those models can be quickly deployed to help guide decision-making. So I'll describe two studies in a bit of detail today, and they both concern the theme of incarceration. Also from I'm sure everybody in the group knows, mass incarceration is a major issue in the United States, and it beyond its various social costs, economic costs, mental health costs. There's a large sort of public health impact that sometimes gets less attention than it probably should. And so my hope is that through this talk, we'll have assembled some ideas from networks, some ideas from agent-based modeling to look at the impact of incarceration on a couple different health outcomes. So this work is supported by various institutes in the National Institutes of Health, and I want to acknowledge the team that worked with me on this, many of whom are based in Chicago or other places in the country, Houston and LA and so forth. So I'll start with just sort of describing what the HIV epidemic looks like. For one, it is very much an ongoing problem in the United States. It has been for decades. And it's a disease that's it's an infection that is distributed heterogeneously, meaning certain populations bear a far more disproportionate impact of its effects. So men who have sex with men in the United States have experienced about almost 2/3 of the total infections taking place annually in the United States, where there's already about 1 million people living with HIV. And even amongst the MSM, or men who have sex with men community, the rates of new infection are highly concentrated amongst Black MSM who experience about 72 times the HIV infection rate in the general U.S. population, and even amongst white MSM, which is a high incidence community, they experience about 3 times as many infections. So one important tool in the HIV prevention strategies is pre-exposure prophylaxis, which is a biomedical prevention pill. It's basically consists of the same chemical formula that's used to treat HIV. While HIV cannot, in a vast majority of the cases, has never been cured, it can be suppressed enough that people's viral loads are stable and their health condition can be managed so they can have a long life. But about a decade-ish ago, it was discovered that basically the same type of medication, if it is taken by persons who are at risk of getting HIV, then it reduces their chances of becoming infected. And so it's a prophylactic type pill. Some clinicians describe it as being not that different from taking birth control, for instance. If you're at risk, your doctor might prescribe you to take a pill a day or so, for as long as you need it. And so this has been found to be remarkably successful in preventing HIV infections, but challenges remain. I think the challenges of the U.S. healthcare system are well known. It's not very easy to scale up medical technologies even when they exist. And so it's great that we have this tool, but scaling it up amongst the most populations that need it the most is extremely challenging. And that's sort of where the work started. We found that about 9 or 10 years ago, when these studies were launched, that only 3% of the Black MSM community, amongst a group that was at substantial risk for HIV, was using PrEP because people didn't know about it, or were not prescribed it, or didn't have enough contact with the healthcare system, or there wasn't trust. There's all kinds of reasons. But here's sort of an interesting graph. We had noticed how the HIV epidemic had been declining. The HIV incidence, which is the number of new infections annually, had been declining in the general population in Chicago. And this trend is largely true of many places in the United States. Yet, the black MSM incidence rate was really stable, if not even increasing a little bit. And so, there's been a great push over the past 7-ish years to formulate strategies to end the HIV epidemic in the United States. And those strategies are unlikely to work unless we can scale up prevention strategies in the populations that need them the most. So, for instance, if the black curve kept going down and the red curve stayed where it's at, we'd still have 500 new infections a year in Chicago. So, that's not going to take us to 0, which is the goal. So, what we did was we wanted to test strategies at scaling up pre-exposure prophylaxis, and we constructed an agent-based model to do that. So, an agent-based model is basically a simulation system where individual agents can represent some sort of entity. For me, it's usually people, but it could be really anything. It could be cells, it could be animals, plants, whatever. Other people call them individual-based models, and they're sort of a powerful technique to study emergent systems-level behaviors if you specify some ground rules of how those agents interact with each other. So we built an HIV model that took into account various sets of characteristics of a transmission system, and I'll show you in a second what they are. And basically, the rules of engagement are derived from a number of different studies that published, including some of our own, where we collected baseline data on behaviors and prevention strategies, healthcare services, et cetera, in our population of interest. So this is what the flow of the model looks like. So we initialized our model, and it consisted of these various attributes. There's demography, which basically means sort of vital processes of births, deaths, and aging. So if you're representing agents, they sort of go through the life cycle in the course of the model, the course of the simulation of the model. They form and engage in networks. In this case, the networks represented sexual partnerships between people. And we collected data on sexual behavior of young black men who have sex with men. The model encapsulates biology, so there's CD4 counts and viral loads that basically describe the immunity and the viremia of persons, that sort of the interplay of which dictates how sick they are, and then treatment provisions, so antiretroviral treatment or pre-exposure prophylaxis. And then, all of these attributes sort of interact together to sort of determine in this population, in this agent population, which is simulated in daily time steps, when two people have sex, what's the likelihood that one may transmit the virus to another? And that sort of event we can simulate because we track all of these attributes in the model. So we have a list of sexual acts that are occurring between one HIV positive and one HIV negative person, and we know for all of those partnerships what the sort of parameters of interest are. What is somebody's viral load? What is the uninfected person's CD4 count? What is their treatment status, like how old they are. It's not real people, but it's an encapsulation of a real transmission system, and we can then sort of run various types of interventions and see how does the population level epidemic change when we roll out different things that are going to influence these daily interactions between people. So this is not a slide I include for other audiences, but you guys are a special group, so I want to just tell you a little bit about what's underneath the hood a little bit. So for this particular model, the sort of heavy lifting is done through the repast toolkit for agent-based modeling, and we use that toolkit to manage a number of different model behaviors that we discussed. So initializing the model, the demographic parameters, the biological parameters, the treatment parameters, and infection. And there is a separate networks package in R that allows us to model the sexual networks between that sort of that are generated through this population with fidelity to the empirical data that we have. And that's sort of, so we linked up our repast ABM, which was written in C++, with this R-based network simulation package. And we took a parallel simulation toolkit called eMuse that allows us to specify different combinations of parameters. So we had dozens of parameters that describe various components of probabilities of interaction, yet many of those data points are not precise. They're highly uncertain, and so we have no easy way to discriminate, well, what's a more reasonable value or set of values to put on a set of parameters. And so sometimes what we do is essentially undertake a brute force approach where we can sort of create a grid of all possible combinations of parameter values and simulate the model across that entire matrix on a high-performance computing system. So, that's sort of a brute force approach. If your model is running fast, you can be more clever about things. You can do sort of more adaptive searching on that grid. But the basic idea is quite simple. You have these uncertain parameters, and you don't know how a complex system is going to respond to those parameter values. And so sometimes we do them all, and we figure out which combinations of parameters produce results that are most similar to what we know about reality. And that's the curves on the right. I won't explain all the scientific detail there, but the main sort of message there is that we were concerned with two outcome measures: HIV prevalence, which is a proportion of people in a population that have HIV, and the incidence rate, which is if you follow 100 uninfected people over the course of a year, how many of them on average would you expect to become infected? And from our survey data, we knew reasonable targets for both of those measures, and so we ran the model enough times so we could calibrate it to these real-world outcomes. So that's sort of a detailed process, but it's a computationally rich problem and sort of speaks to some of the big data considerations that I'm sure you talk about a lot in your work. So just to give you sort of some overarching picture of what the population looks like, there's 10,000. It was representative of about 10,000 young black MSM, which was roughly the estimated number of young black MSM in the city of Chicago. We had some parameters on PrEP, how many were on PrEP, how on average, how long people using PrEP were using it for. And once the model was calibrated to the outcomes we saw on the previous slide, then we could run public health interventions on our model, which were of direct interest to the public health department. They were interested in providing services to the population, but it's not easy to tell, well, given all these uncertainties, which one is likely to have the greatest benefit. And that's where modeling comes in. So we ran a bunch of different interventions on the population. We looked at, basically what would happen if we randomly gave out PrEP. We looked at serodiscordant partners. So if we were to identify in the population people who were HIV negative, but whose partners were HIV positive, if we just scaled up our PrEP resources to provide PrEP to them first, versus if we did a network position type investigation. So we identify who's in some sense central in the network and provide PrEP to them. And we found that the serodiscordant couple strategy was the most effective. If we scaled up PrEP to about 60% of such couples, we would go down to about 100 new infections a year, at which point the new incidence count is low enough that it would start to die out on its own. It's not a literal zero, but it's like a functional zero. So that's what the model suggests, and that's great. But in real life, it's really hard to do that. It's very hard to know who are all the HIV negative people in the population that have HIV positive partners, and there's many reasons for that. One is many people often aren't aware themselves of their HIV status, and even if they did know, they may or may not feel comfortable sharing it with that information with their partner, and there's sort of all kinds of complicated relational dynamics, and then their comfort in sharing that information with the health provider, and so on. So there's various barriers to what scaling up that information actually might look like. So, we talked about this with the Chicago. Yeah, please. Yes, please.
So I'm curious, in your modeling, do you take into account, for instance, whether they use protection,
Yeah.
how many partners they have,
Yeah.
and what type of sexual activity?
Yes. Yeah, we collect data on all of it. So the.
You didn't mention any of this,
Yeah.
I was wondering.
Yeah. That's a great question. Yeah, it's basically when the recruitment happened, our study participants were invited to participate in the study, and if they chose to do so, then they were provided a detailed biobehavioral questionnaire, and those types of questions were part of that questionnaire. So how frequently they use condoms, and how many partners they've had in the last 6 months, how many partners they have right now, and so on. And so there's a range of sort of parameters that go into parameterizing that model. So yes, that information is there. So we went to the Chicago Department of Public Health and sort of discussed this with them, and they felt like one area where there was greater visibility in health effects, and where it's sort of easier to at least in which sort of the effects are so structural that you can't miss them, is one such example is incarceration. So you have this like highly disruptive force that affects the black community extremely, much more than most other communities in the United States, and it's highly disruptive to all kinds of things. It's highly disruptive to healthcare. It's also highly disruptive to social network stability and all kinds of other things. And so, and we felt like if we have to make progress towards eliminating HIV infection, we know where some of these biggest pain points are, and that's where we sort of need to go first. And so what we did was we included then a sort of incarceration specific module in our surveys and collected data on what the incarceration parameters in the population look like. So, how many people have experienced detention or arrest recently, and how long they've been away, and sort of what sorts of effects it's had on their engagement with the health system and their sort of stability and housing and so on. And we incorporated those effects to the degree we can in our model. And the main parameters that we focused on was what was the general incarceration rate amongst never incarcerated persons, what was the recidivism rate, so what is the incarceration probability rate for persons who have experienced incarceration before, and the mean duration of detention, and we sort of built those parameters into the model so we could track what segment of our agent population had been incarcerated or was under incarceration, and doing sort of more explicit modeling of the sexual networks and the healthcare parameters of these persons. So, so basically, that's Cook County Jail, where the study, some of the surveys were run. It's the third largest jail system in the United States, and we went through again sort of the model calibration process that I alluded to a few minutes ago, and what we found basically was that under the status quo, that is the patterns of care that were observed, that people reported, HIV incidence amongst people who were partners of people coming out of jail was twice as high as other people in that already high incidence population. And the reason for that is essentially that when people come out of jail, they lose contact with the healthcare system. And once you lose contact with your healthcare system, and you're HIV infected, your viremia shoots up. And once your viremia shoots up, you're more likely to transmit to other people. And so, so certainly that's a group that is bearing a disproportionate health consequence of incarceration, and yet it's important to remember sort of what's going on in the vicinity of those people as well. And that's the part that is very hard to do through classical empirical studies or surveys for many reasons. But, our model helped sort of shed light on looking at the network of those people. And that sort of ties into the theme of this talk, which is, health is sort of a clustered effect. It's not just about individual behaviors and outcomes. So this slide just shows the magnitude of viral load amongst people who are coming out of jail and whose engagement with public health may have been, or their care provider may have been disrupted, and their viral load can be, and consequent infectivity can be 2 or 3 times that of the baseline population, and that's sort of what drives the high incidence in their amongst their partners. So there's a lot written on this slide, but the main summary is this, that HIV elimination is a complex endeavor. There's many moving parts here. There's lots of strategies people are coming up with that they're working with at a community level, at a healthcare provision level, yet it's not always obvious, given all these sort of uncertainties and trade-offs, which is likely to be the most effective. and that's kind of where data science and modeling can come in and help shed some light on what are the sort of mechanics that are driving the disparities or whatever the outcome of interest is in a particular system, but B, perhaps more importantly, what mechanisms of change there are that can help uh, mitigate those effects. How are we doing on time, Alden? Good. Yeah. All right. So this is sort of a second research study that builds upon some of the same themes. And this is work I started in Rhode Island when I moved here 2 years ago with colleagues in the School of Public Health. Primarily, some of you may know Yurui Zhang. He's an MS student in this program, and he's been working with me for about a year on doing the modeling for the next project that's supported through the NIH and a grant that faculty have at our School of Public Health. So some of these themes I think we've already talked about. Incarceration has multiple health effects at multiple levels of a population system. Modeling allows us to integrate the effects across various levels of that system. And in this particular talk, we are more interested in the substance use effects of persons who are involved with the justice system, with the criminal legal system. So essentially, the idea is this. Going to jail and coming out is a highly stressful life circumstance. And smoking and alcohol use are well-known coping mechanisms. So people go through a stressful life circumstance, they may be more likely to take up smoking or heavy drinking. Yet, those effects are not restricted to the individual persons alone. If my friend or a family member is incarcerated, I would feel a lot of the stress too. And I'm just as susceptible during those periods of vulnerability to engage in those types of coping behaviors that are known to be harmful for health. That stuff aside, there's sort of separate literatures on how, on the sociality, if you will, of smoking and drinking. So people who smoke or people who drink tend to cluster together. In fact, a lot of those studies are actually conducted amongst college students, especially the ones on heavy drinking. So there's a network angle to this stuff to begin with, and so you put all these things together. You put sort of the stresses induced in people's lives through incarceration. You take into account that those stressors are not limited to just the people who are cycling in and out of jails, and then the fact that these are sort of networky behaviors anyway, and you sort of have what we could call a syndemic condition where you have multiple interacting conditions that affect the whole community, basically. So the purpose of this study it's still ongoing, is to estimate how much more likely people who are in close relational ties with persons who are cycling in and out of the correctional system, how much more likely are they to smoke or drink heavily than the general population? And part 2 of this study, which I haven't gotten to yet at all, but it sort of links it to downstream health outcomes like cardiovascular disease risk factors and so on. So step 1 is to just, in the way that we designed the study, is to just get a handle on what the substance use behaviors are, and part 2 will be linking them to chronic disease outcomes. So we start with a very similar type of flow chart that we looked at in the last, while talking about the HIV study. So you initialize a model, you sort of simulate various demographic parameters. There's individual smoking and alcohol use. There's social network reinforcement of these behaviors. People undergo incarceration, release, recidivism, and so on. And then there's post-release smoking and alcohol use. And all of these things put together can produce aggregated synergistic effects across the system. And we don't know through purely empirical studies the magnitude of the problem, because it's just expensive and hard to follow all the people that would need to be followed in the real world to get that kind of data. And so that's where, again, modeling comes in, where if you have enough data on some parts of that system, you can start to aggregate those effects in a computational laboratory, basically. So just sort of going through the steps of what this is, so we basically constructed a synthetic population that's, has the same demographic distribution as the general population of Rhode Island in terms of sex, race, and age. We simulated basic alcohol use profiles, so there's data on how many on drinking behaviors, and so we categorize them in one of four behavior in one of four states: lifetime abstainers, occasional users, regular users, and heavy users, and figured out sort of what the transition probabilities between those states should be, so that our distribution of those states in the population matches our empirical data. And Yuri, from your program, really sort of led that part of the work. We did the same thing for smoking, where we had data from Center for Medicare and Medicaid Services on the distributions of never smokers and persons who are currently or former smokers, and again, sort of estimating what the transition rates between those categories should be, so we have a state distribution that's empirically reasonable in the model. We had incarceration parameters from the Rhode Island Department of Corrections that have been published in previous studies from our university before, and we built those parameters into the model. And finally, network structures. So the conceptualization of what a network constitutes is different from the HIV study. Here we are sort of more interested in, not just interested in sexual partners, but more interested in a close bond, which may mean a close friendship, a family member, or something like that. It may include sex partners, but it can also include other forms of social connectedness. And recent data have reported that American adults tend to report about 4 such people in their lives currently. And of course, it probably varies a lot by various attributes, age and race and so forth. But as a general principle, that's sort of where the data that a few different sources have suggested. And we can sort of take that information and generate it into a network diagram and sort of look at what a population of smokers where about 11% of the current of persons today currently would be classified as current smokers, and that's kind of what it would look like in the context of a model. So what we are doing here is, so we have, those 3 slides sort of describe what's the sort of bare minimum that we need to put the model together. And this is sort of where things start to get interesting. So there's separate data on how smoking and alcohol use, published from the Framingham Heart Study in Massachusetts, that describes to what extent heavy drinking and smoking behaviors tend to cluster in social networks. So basically, we can take that data and seed our model in a way that if somebody is connected to a person who smokes or who drinks heavily, their own probability of smoking or drinking heavily increases by that amount. And we have separate data that looks at incarceration and smoking and incarceration and alcohol use. And that's another sort of parameter that can be built into the model. So we have people who are agents who are coming out of jail, and so they're more likely to smoke or drink, and we know roughly what those probabilities are through our data, and we can run this model and then stratify what smoking and drinking looks like in amongst the social networks of people involved with the correctional system. That's not something that there's much information on in the real world, but running it through the model can help sort of make that connection. So that's work in progress. I have some data, but I'm not sure that they're right, and so I didn't want to put them in the talk. But essentially, where I'm at in the project now is sort of running the model and calibrating it and measuring these types of outcomes. So, what are the rates of smoking and drinking in agents who are involved with the correctional system? What are the rates of smoking and drinking amongst persons who are connected, socially connected to those people? And the next step of the work will then be sort of simulating interventions and connections to downstream health conditions. So this is, ongoing work, and if any of this interests you, Yurui used his work on this project as part of his data science practicum, and if this is of interest, if anything that I've discussed catches your fancy, please reach out. I would love to talk to you about what I'm doing, and I think what I'm looking for is some facility, but more interest in learning about the computational tools that can help do public health work. These are sort of the tools that I use on a daily basis. I program a lot in Python and R. I do a lot of this running my models on the high performance system that CCV maintains, and then the EMU's toolkit that I described earlier allows us to generate data, large quantities of data in parallel, because we need to sort of be adaptive and efficient in generating and analyzing the data that we are trying to sort of study. So that's it. I thank you for your attention and for coming today. Yes?
For the second project, you take into account the dynamics of interactions, like for example, like if the custody during the time of custodiation more cluster together for interactions, but sparse interaction with the family, and then most will be more interaction with the family.
That's a really good point. I actually hadn't thought about that. That when they are incarcerated, they're probably closer to a different set of people than when they're outside. Yeah, so that's a great point. I think that's something I should go back and think about. One of the things that we did try to address a little bit is the extent of smoking and drinking that goes on in the jail itself, and it seems that in the Rhode Island Department of Corrections, we talked with the warden, and she told us that the rates of alcohol and smoking are very low. In fact, smoking only may occur when people are sort of out on, these work trips, so construction crews and so on. I didn't know this, but sometimes they are people who are otherwise incarcerated, and while they're working, they might smoke or drink. And then other circumstances, sometimes when they are re-entering the community after release. They may stay in a temporary housing location known as halfway houses, and some may take up smoking there. So there's various levels at which these effects can sort of start to take hold. And yeah, I'm not sort of really only started to scratch the surface of that at some of them. Yes,
I'm really interested in the model of the HIV
Yes.
and the carceral system. So one question I have is sort of what happened in that study? Were you able to make a case for focusing on people that were incarcerated? And the second question, to my knowledge, I don't think, do prisons administer or allow prisoners to take PrEP?
Yeah, great questions.
I
Both of
don't
them
think
good
they
questions.
do.
No.
They technically people aren't supposed to be having sex in
Yes,
prison, so
yeah.
there's okay.
Yeah, they don't. And in fact, what we modeled in that study was, you know, if people are infected with HIV and that's known, then their treatment continues when they're incarcerated, but there is no drug in the Chicago jail. And, you know, yeah.
So I was just wondering if you were able to make the case to the system that maybe you should be giving prisoners PrEP based on your model.
Yeah, we did, but, but you know, the reality is sort of,
Yeah.
you know, it's, yeah, yeah, there's just so much stigma around PrEP use and HIV that even if it were to be offered, I think the uptake in a closed environment like that could be very challenging to increase. But I totally agree with the sentiment that, you know, it's clear that that would have an effect.
Mm-hmm.
And certainly, you know, continued care upon release from jail, because that's the really sort of high vulnerability period where, you know, you may have had prior contact with the health system, and then if that continued while you were incarcerated, when you come back out, you've lost it from both places. You've lost it from your prior contact, and you've lost the sort of support that you may have been getting through the jail system. Yeah.
So these are kind of like very sensitive areas of like data
Yeah.
sources. Is there, for example, with the incarceration, like we're talking to wardens or the warden reporting, is there any concern of underreporting?
Yeah.
And
Yeah. Well, yes. There is a lot of, you know, I think stigma, underreporting, various biases, those are all, and that's part of the reason why I sort of went through a little bit about the calibration process and the uncertainty of parameters, because, you know, we have data and data reported, and, you know, sometimes people may not remember, you know, or they may not feel comfortable sharing that information with someone like me, you know, they don't know or whatever, you know, and so, so we have to, sometimes we take those data, we build a model, and then it matches the real world outcomes we care about in some ways, but not in others. And so then it becomes this like, almost like a balancing act with, you know, you have all these different parameters with some degrees of uncertainty, and how do you incorporate that uncertainty in your estimates into the model to generate data that are consistent with what we know empirically. And that's, in my view, the hardest part about, that's where I sort of spend, you know, my longest time every time I do start a new project or extend one. It's, you know, trying to figure out what are the outcomes we care about and how to make those simulated emergent outcomes be reasonably close to the measured empirical data.
I'm wondering, when would modeling not work? So I'm thinking about my own research, which is related to more communities of color uptake of digital health technology, right? So would modeling, like creating a synthetic population and modeling work for something like that? Or are there places where modeling doesn't work as well?
Well, so I think the hard part about the model is getting it to work. I don't see that as a binary question. Does it work or does it not work? It's more sort of an open-ended. How can we get some information that we don't get otherwise, or that's very hard to get otherwise? How can a model help us get that?
Got it.
And sometimes after trying things, maybe there is really not much that a model can. But I think it takes time to sort of figure out where the gaps in knowledge are and what sort of tools are out there that can help us sort of make some reasonable assumptions or derive rules about how a system operates at multiple levels, and then try to figure out something about what we don't know. So it's really a process. And in my view, even if in a sense the model doesn't work, you learn a ton by just putting those things together. That's kind of why I do it. I sort of think that even when the model is limited, you learn a great deal by assembling these pieces of a system together.
All right, thank you.
Thank you. Thank you so much.